Hello, everybody. Thank you so much for joining us. Welcome to our Talk with the Doc panel. My name is Sheila Taylor, and I am the 2020 More Than Pink Walk Chair for North and West Texas. I am also a 3-time breast cancer survivor, so I feel honored to be able to sit here with our esteemed doctors and be able to ask a few questions. First, I want to introduce our panelists, and again, to thank you guys, thank our panelists for joining us for this afternoon's talk about breast cancer screening, diagnostics, and treatment during a global pandemic. First, we have Dr. Kevin Thomas. He's the Chief of Surgery for United Regional Healthcare System in Wichita Falls. Dr. Thomas specializes in breast, general, minimally invasive and robotic surgeries and is board certified by the American College of Surgery. Next, we have Dr. Kevin Tulipana, the Regional Medical Officer for Cancer Treatment Centers of America. Dr. Tulipana is board certified in family medicine by the American Board of Family Medicine and specializes in hospital medicine. Last but not least, of course, we have Dr. Rakhshanda Rahman from the University Medical Center. Dr. Rahman is an ASCO Endowed Chair for Excellence in Women's Health, a professor and associate chair of research in the Department of Surgery, and the director of their Breast Cancer of Excellence. Again, thank you all for being here this afternoon with us. Now I want to kick us off by asking a question, and it is, what changes have you seen in your practices or hospitals since COVID-19 has started?
Who wants to start?
Go ahead.
Well, since COVID started, the hospital obviously quit doing elective cases initially, and we stopped that for a period of time. When things opened up, we opened up our ability to do elective cases with the COVID testing prior to surgery. So we had to limit our volume initially to make sure that we could handle the COVID cases in our institution. And as that became a doable proposition, we were able to really kind of crank up to, at this point, we're at 100% of our volume. So it really didn't, it doesn't change, it hasn't changed, in my opinion, the aspect of the surgical approach to breast disease, even early. But there was a little bit of a hiccup initially as we encountered the COVID pandemic in Wichita Falls.
Gotcha. Dr. Tulipana?
Yeah, we had several changes initially things that we recognized or noticed initially was the number of people that weren't coming in that normally would have been, whether it be for their treatments or their early diagnostics. So we really began to institute protocols to mitigate any potential risk to our patients.
Mm-hmm.
We're at an advantage here at Cancer Treatment Centers of America in that all we take care of are the cancer patients. So we were able to really ask that anybody who was ill, even early on, just to stay home for a period of time. We did begin to institute a lot more remote healthcare. So we would react and identify and talk with our patients remotely or through telehealth to identify whether or not it was safe for them to come on up and continue on with their treatment. So those were some of the early things that changed.
And it's interesting you say that because going in for I had to do a chemo class, and I did that through telehealth. So I was really thankful for that option.
Yeah.
Dr. Rahman, you want to add anything?
So yeah, there were several different angles. First of all, right off the bat, from a screening perspective, when originally the shutdowns had started to happen, for a while there, at least I want to say about a 2-month period, we didn't do any screening mammograms of asymptomatic people just to keep the traffic flow in the mammo area.
Mm-hmm.
Then we slowly started the screening process, and what we did was we didn't want people to be hanging out in the waiting room. So they would sit in their cars, and we would just call their cell number when their turn comes in, so they could come and get the screening and leave.
Okay.
Diagnostics, similarly, we did it that way so that the traffic and basically huddling in a room is what we wanted to avoid. And of course, all the precautions about the hand washing and masks and stuff were in place right from the word go.
Yes, thank you.
From the treatment perspective, every patient that had chemotherapy, we got pretty early on the testing supplies. So we were, in our cancer center, the policy was that every new chemotherapy patient that would be started had to be COVID negative before we start chemotherapy.
Gotcha.
So that just added a wrinkle to the things to do before chemotherapy. The telehealth, we did a lot of telehealth as well, but I would say a little bit of another point of view on that. Patients who are survivors who've been very familiar with the system for several years and know how the whole cancer system works, they were relatively comfortable doing their survivorship follow-up on telehealth.
Gotcha.
New patient diagnosed with cancer and just got the big C word was not very comfortable not actually knowing their physician face to face. So we had some hiccups on that. Some people agreed and did well. Some people insisted on an appointment, and we did see them in person in the clinic for that angle. The other aspect that we had to consider, because we see a lot of patients from New Mexico and from Oklahoma, for example. So sometimes people enjoyed the telehealth visit because if they came for an appointment, then because they left the state, they had to quarantine back home when they got back home. Because New Mexico's rules were if you left New Mexico, then you had to quarantine. So some of that played out a little bit as well.
Gotcha. So
lastly, on the surgical side, I would say that we had a hold on elective cases. So people who were ER positive tumors, most of them ended up on neoadjuvant endocrine therapy while we were buying time before we could operate. And people with high risk tumors who we couldn't wait, we did an outpatient line clinic system of putting in their ports without taking them to operating rooms so they could get chemotherapy. So nobody's care was technically delayed, but we had to get creative about how we go about it.
Yeah, definitely.
And the last point I'll make is a little bit of an innovative thing because we are one of the participants on freezing the tumor trial, which is not standard of care, but small early stage disease can be frozen without having to take people to OR. Right now, that option is available as a trial participant to the patients. So many patients opted to have a cryoablation as an outpatient to avoid going into the hospital and getting surgery.
That makes sense. A lot of what you said. I did have a question. I'm going to direct this to you, Dr. Thomas. Are there things that patients in treatment should do to further protect themselves while they are immunocompromised?
I think they need to take all opportunities they can to try to stay obviously away from the patients that are at higher risk for COVID. And I think that, the shelter in place probably is more applicable to those patients than anybody. We changed some of the ways we handled those patients early before some of the CDC recommendations really got hammered down. And we were doing the same things that was discussed before, bringing them in out of their cars, not having them congregate at all in our waiting areas. And moving forward, I think that still needs to be something we need to consider. Having a patient come in post chemotherapy in my office before was a face-to-face encounter. Moving forward now, it may be something that, we truly consider. We'll offer them the option to have a mask when they see me. And of course, I would probably see them ongoing until this whole COVID situation kind of goes away. So I think we're a little bit more attuned to that. There's a lot of controversy in all this too, and that'll all get ironed out also. But I think just, patients' wishes and comfort and trying to do what's considered the standard from a scientific standpoint is what we'll do moving forward.
Okay. Dr. Rahman, do you have anything to add?
Not really. I think that I'll just do a different angle again on these things is the cancer patients and patients undergoing chemotherapy are kind of auto-prepared for a COVID type situation because the precautions that chemotherapy patients take normally without COVID are pretty much up there anyway. It's just the rest of the people recognize that to up their game a little bit. It was a little bit surprising to me how many people discovered the art of hand washing.
And using hand sanitizers. It's everywhere when I go to the oncology.
It should be COVID or no COVID, that should be standard practice.
That should be standard. I totally agree with you. Dr. Tulipana, anything to add? I guess that hasn't been mentioned.
No, I think they all.
But what we're all saying is, protect yourself, the mask, the hand washing, the socially distancing, and we're all trying to do that. I've run into that with trying to decide to send my daughter back to in school, but I'm in chemo, so I was like, I gotta be extra careful, as you guys mentioned. Now, this is a question that was very important to me to ask because I don't know the timeline. So when you're going through chemotherapy and you're immunocompromised, how long does it last? Does the immunocompromised situation last after you're done with chemotherapy? You want to weigh in there, Dr. Thomas?
Well, I've read some literature that says up to 9 months. I don't think anybody really knows, and it has a variable based on the treatments that are given. But I definitely think it's something that needs to be thought about long term. And Dr. Rahman may have a better answer than I have for that. She's probably more attuned to that
Yes.
scenario.
Dr. Rahman?
So the couple of things to understand. First of all, we do suspect the baseline immune status of people who get cancer in the first place. Because I mean, cancer and immune systems fight is what causes people to have cancer, means somehow the cancer won and your immune system fails. So that's one angle to just understand. The second aspect is if you have comorbid conditions like diabetes and stuff, then that adds the injury to the, adds insult to it. So that's the other area. Now, if you go to very nitty-gritty of chemotherapy, that actually a piece is short-lived, because once the day you get the dose, the count drop in your bone marrow is usually about a week and maxes out about 2 weeks, which is why the chemotherapy cycles are spaced out the way they are.
Gotcha.
Because we wait for your immunity to come back so we can give you the next dose. So if you go by that definition, you should ideally be okay 2 weeks after the last dose. But the first two things I mentioned are hanging out there anyway. So a cancer patient's immune system is not equal to a non-cancer patient's immune system, but that they do get back to their own baseline relatively quickly.
Gotcha. That makes total sense. I wondered about that because I was like, am I good? 3 months out, 2 months out, 2 weeks out. So that makes sense. And like you mentioned, when I go to the oncology center, they are always looking at and documenting my counts. And I remember going and I got off schedule because one time when I went, maybe the time before this last time, my counts were so low that they didn't want to give me chemo. So I ended up off that 3-week schedule. So that's really important for our viewers to know. Dr. Tulipana, what changes in healthcare practices that have been implemented during this COVID-19 do you anticipate continuing even once this crisis is over?
Yeah, I'll preface that just a little bit with what changes in healthcare have probably impacted cancer, especially cancer. Only because I think it's important to recognize that Dr. Rahman mentioned that the number of screening mammographies were initially dropped off, and they continue to be lower than they should be because people are fearful to go in and get their routine screening. So we've kind of discussed that and talked about it within our organization as something we call the shadow curve. There have been some studies that have shown that, the new diagnoses of breast cancer in particular is down almost 50% over a period of time. And it's not because there's less breast cancer out there, it's just not being identified early. So those changes hopefully will go away. Those are changes that have happened because of COVID that I hope go away very soon. And if people get back to their routine screening and get back to their routine healthcare and get back into the offices, it's going to make a difference. I do think that things such as the implementation of remote health and telehealth are here to stay, particularly when it comes to follow-up visits. We've seen a significant adoption of that. And I think it's a good thing because it's going to give access to a lot of people who didn't have access to healthcare before that, to those interactions with their physicians or clinicians or other personnel. So I do think that that is something that's going to continue even beyond COVID. We've already seen changes in CMS or Medicare guidelines that would reflect that.
Gotcha. Okay, thank you. Dr. Thomas?
Yeah, I'm kind of old school and have difficulty with this computer stuff. So telemetry medicine I haven't really fallen into. I have a young partner that really enjoys it and is using a lot. So I agree. I think that's a great thing moving forward. I'm a big physical exam kind of guy. And that's the thing I think is a little bit lacking in the conferencing like this. We don't have the physical contact. And I think that's important and not to be left out.
Correct. I agree. Dr. Rahman?
Yeah, I think I agree with both the other panelists. Everything is good and bad. And one of my mentors said the best thing is technology is a very good servant, is a very bad master. So I think we'll have to be very selective. On one hand, it does provide access, but my fear is that it will stay and be adopted even in situations where it may not be very appropriate. So
Gotcha.
all of us who are into teaching will tell you that only time the residents and students get in trouble is because they did not do a good job at physical exam. And
Mm,
so I always want to underscore that, and that is a very, very important piece. One last point I just want to, it's a sad story, but I want to share that because I want to create awareness on this area, is the fear factor. There is a healthy fear which makes you careful, and then there is too much fear that makes you make bad decisions. I lost a patient of breast cancer of mine, a young woman with she had advanced disease, but no, I mean curable disease.
mm,
Got chemotherapy, first cycle of chemotherapy, was from New Mexico, had diarrhea at home, and somehow couldn't keep her fluids up or whatever. She was so scared that, oh, if I go to hospital, I will have to come back and quarantine, and my local
mm,
ER, I don't trust, so I wouldn't go. And so she
mm.
just did not connect back with the system. And literally middle of the night asked her husband to help her to the bathroom and collapsed and died in the bathroom.
Oh my gosh.
So she didn't die of COVID, she died of fear of COVID.
Yes.
So I just want to make sure that people recognize that, you know, doing your social distance, washing your hands, maintaining your hygiene is good. But when you are
Mm-hmm.
that sick and you need to be in the ER, you need to be in
You
the
need to
ER.
go.
There is no tele approaching that.
Right.
So I do think that some of the fear got the best of us sometimes, and that was a
Mm-hmm.
very sad loss. I mean, she was a young mom of 2 kids.
Yeah. Oh,
And
Jesus.
so I just want to make the point that people recognize that every extreme of everything is bad.
Yes, I
So we
totally
have to
agree
be
with
able
you.
to strike a balance in
Yes,
order to do the right thing for every situation.
I agree with you on that. I have a friend I was just talking to not long ago, and she was talking about her symptoms and asking me questions. And she's 40, which is that age where you're supposed to have the baseline mammogram anyway. But like you mentioned, the fear, so scared to go in. I'm scared to find out the result. I'm scared of COVID. But in the meantime, she's Googling, which you guys know is probably a bad thing, that you probably tell your patients not to Google
Right.
information on symptoms and all that. So she's convinced herself something is wrong. And I was just trying to, you know, encourage her to go and get it checked out, because you have better, obviously better response rate to treatment if it's found earlier. So I appreciate that. Now I had another question going off script, just based on sort of my experience with this and having to do 2 surgeries, you know, without my husband being there by my side, having to go through chemo before all my friends, you know, would take turns coming and sitting with me. How have you guys, and I'll direct this to you first, Dr. Rahman, how have you guys managed the mental health of your patients, or does that come into play? Again, with the socially distanced guidance, you know, some patients are home alone going through this. So is there anything that you guys have or your offices have done to help with mental health?
Yes, we do. First of all, our normal program, every new appointment we have a psycho-oncologist on site, and
Mm-hmm.
for every new appointment, he's available. Like patient doesn't even have to go to another room. So we
Mm-hmm.
just see them. And of course, he has some inclination from baseline distress screening score as to how distressed the patient is, and that counseling is available.
Gotcha.
That is the area which is actually perfectly amenable to telemedicine.
Mm-hmm.
So
Mm-hmm.
what we did was we had a lot of follow-ups on them on the telemedicine part of it. What we did for the COVID special, which is what we normally don't usually do, when we know that the patient is living alone by themselves in the house, we just had scheduled checked calls on them anyway.
Gotcha.
So our nurse navigator would call these people basically before, what we call it, before every major event. So before
Okay.
chemotherapy, 2 days after chemotherapy, before lab draw, post-ops, to just check on them as to how they're doing and feeling. And in case of anything that she picked up, if it's a surgical issue or a medical issue or a psycho-oncology issue, she would appropriate that call to the right provider so we can have a further discussion. That's how we kind of took care of it. But I will say that my observation is that the social distancing did cause itself a lot of distress to a lot of
Correct.
people. I mean, we are
And
social
depression, you're
animals,
right.
and that was
Isolation, all
hard.
that.
Yeah, it was hard for many people to go through isolation. especially, I mean, I have lots of grandmothers new grandmothers couldn't visit or touch their grandbabies or hold them and things like that. That's hard on them because first of all, they have this deathly fear. Okay, now I have cancer. I don't know how long will I enjoy my grandchild.
Right.
Let alone that I can't even touch it or see it or
Yeah,
hold it.
exactly. Right.
So we had to do a lot of counseling in that regard.
Related to that. Okay, thank you. Dr. Thomas, have you seen anything, I guess, affecting the mental health of your cancer patients with isolation, loneliness, et cetera?
Yeah, there's a lot of anxiety, and we don't have the setup that they do in Lubbock, but you know, we try to answer the questions the patients have. We try to tell them there is going to be somebody available. You're allowed to, in the hospital, to have one visitor for all of your care through the transition. So we just try to, you know, answer the questions they have, make sure that they have somebody can be there, tell them what the options are, what our follow-up is. And I follow my patients from a surgical standpoint pretty frequently. So we're pretty upfront with them about that. And that seems to alleviate some of the anxiety that they have.
Gotcha.
Obviously, the COVID things just across the board has caused a lot of issues.
A lot of distress. You're exactly right. Dr. Tulipana, you have any thoughts there?
We intimately involve our behavioral health professionals with all of our patients when they come in, and they'll follow them longitudinally, and they're also everyone is assigned a nurse navigator, care manager that keeps in close contact with our patients. And we too instituted early on a process to allow folks to identify one family member or friend that would be with them during treatment and surgeries and all of that, because we recognize early that is a real thing. I mean, the fear alone from having surgery or undergoing chemo is immense, but then to do it alone, that's even worse. So recognize that early. There is tremendous impact. And we know that the more stress and anxiety, the less, you know, you're not going to do as well regarding the treatment. You just respond positively. So
that's right. Positive attitude means everything. Well, I'm being told to wrap up. Before I do, I don't have any more questions, but I just want to know if you guys have any final thoughts on, you know, dealing with breast cancer during this COVID-19 pandemic that seems non-ending. Anything that you haven't mentioned before, or any last thoughts?
I would just start with, you know, get back to doing, you know, those who don't have cancer and need screening, get back to it, make certain that you're on track with that. Follow up with your doctors if you've lost touch with them.
Okay. Dr. Thomas, any final thoughts?
You know, again, the patients we follow up for either benign disease or cancer disease in the past, I think that I just reiterate to the patient the importance of self-exam. Again, if their treatments or follow-ups are delayed for whatever reason, that's probably one of the most important things they can do. But I think that, you know, at this time moving forward, we should be pretty well back to our normal regimen as far as taking care of our patients.
Gotcha. Dr. Rahman, any final thoughts?
Same thing. I would say that some amount of fear is healthy. A lot of fear is unhealthy. COVID is a very unfortunate situation, but it is a situation that it's like when a train has an accident, the first 4 carts will get most damage. The first 4 carts will always be first 4 carts. You can't prevent the damage by removing the first 4 cart because something else becomes the first cart. So the point I would say is being careful is one thing, but we really, and I'm trying to say it in a very pragmatic way, but not trying to offend people. So that's why I'm searching for words here. But the bottom line is, by keeping people from living, we are not going to keep people from dying.
That's a great way to put it.
So I am really worried about unhealthy level of fears, which is not going to prevent COVID, God forbid, if you're destined to have it.
Right, I understand.
But we are creating more other causes of death, and so people need
that
to
fear.
be a little bit careful. And again, I'm going to go out on a limb. In those type of situations, I would say that let's not forget that there is a God.
All right. Well, thanks, guys. This has been so informative for me, and I know informative for our viewing audience. I just want to thank you guys again. Thank the panelists, Dr. Tulipana, Dr. Kevin Thomas, Dr. Rahman. Thank you guys for joining us today and giving us some of your time. I want to thank all of our viewers who are watching, And then I want to remind you, as the 2020 walk chair for the More Than Pink Komen North and West Texas walk, that Komen North and West Texas is here to provide support to men and women who need, in our area, who need services for breast health. You can learn more at their website, KomenNorthwestTexas.org. That's KOMENNWTX.org. Thank you guys again for joining us today, and I am signing off. Goodbye.
Thank you.
Thank you.